Welcome to AETCM, the Emergency Medicine Channel.
Yeah.
Today I'll be presenting a case of 34-year-old female who presented to ER with alleged history of slip and fall from bike around 7 hours prior to the ER presentation and with complaints of diffuse abdominal pain. On 10-second assessment, patient was conscious, oriented and talking full sentence. Airway was patent, there was no gurgling, secretions of pooling of saliva. There was no C-spine tenderness or restriction of the spine movements. On breathing, patient had a respiratory rate of 18 per minute with a saturation of 98% at room air. Bilaterally, chest excursions were adequate and air entry was bilaterally equal. On circulation, patient had a BP of 140/90 mmHg with a heart rate of 108 per minute. At this time, 2 large bore IV cannulas were put. On disability, patient had a GCS of 15 out of 15 and pupils were equal and reactive to the light. Patient had a pain score of 8 out of 10 and at this point of time we had given IV PCM 1 gram stat after ruling of drug allergy. Coming to the exposure, patient was afebrile and patient had a GRBS of 126 mg per deciliter. There was no external bleeding, there was no petechiae or ecchymosis and patient was prevented from hypothermia. Coming to the adjuncts to the primary survey, at this time we had done an EFAST due to the abdominal pain and tenderness and the ultrasound showed as perihepatic free fluid collection. There was no pleural effusion or pericardial effusion, there was no fluid in splenorenal and hepatorenal pouch. Then we had come to the patient, we had ordered a CBC CRP to note whether there was any HB loss and the HB of the patient came to be as 8. And then we had taken a VBG to look whether there was any acidosis, but the VBG was fine, there was no acidosis. Then we had reassessed the vitals of the patient and the BP was still 140/90 mmHg and on pain score assessment, the patient told it has come to 7/10. At this point of time, since the vitals were stable, we had sent the patient for a CECT abdomen. And during that time, we had kept the patient at NPO. The CECT abdomen result came to be as laceration of spleen with intraparenchymal hematoma involving the anterior aspect of lower pole of spleen with periplenic hematoma noted. There was a hypertension lesion consistent with hematoma noted between the left lobe of liver and the spleen extending into subdiaphragmatic region. Splenic arteries and veins were patent and there was no aneurysm or fistulas. There was no pneumoperitoneum.
So, patient, what was the age of the patient?
34 years old.
34-year-old female. Mechanism of injury?
Coming to the sample history, patient presented...
You have to do sample history, secondary survey, then only she should go for a CT. That should be the order. Okay. So, you have presented this way, rotately, what we have to do? Life-threatening, limb-threatening. So, stabilize the patient. Then you go ahead and adjuncts. Whatever is adjuncts is 3 things that you need to remember. Any X-ray that is required, 2 X-rays only comes as adjuncts. A chest X-ray, AP view and a pelvis X-ray. Then FAST. FAST is not an adjunct, it is part of your primary survey. That's what I always say. So it's a part of your primary survey. You've done a FAST. Then you have done some intervention. The next step is reassessing the vitals. Go for sample history. Then proceed with sample history. Then you go ahead, do a head-to-toe examination. Then you go ahead with a CCT. That should be the order. You would have presented this way. It should be the other way around. When you have a trauma, that's what I always say. Whenever a patient with trauma comes, the first thing you should know is the mechanism of injury. So always make it a habit. What is the mechanism of injury? You said it was?
Patient had an alleged history of slip and fall from the bike. While she was driving the bike, she had applied sudden brake and then just fall from the bike. So she had hit the ground, hit the abdomen while falling into the ground.
Okay, so that is exactly the mechanism. So from the history, whatever you are giving me, I have come to a conclusion that the mechanism of injury, it is not a high velocity injury. It is a little bit of a low velocity injury, but there is a direct impact on the abdomen. So that is what we have come to know. Now, the thing is that what was the floor? It was on the road only. So it was on the road and she was driving and sudden brake, she had fallen down. So there is some amount of acceleration, deceleration also. And that force definitely would have come for her while she was falling down. and she had abdominal pain when coming to the ED. So here you went ahead with paracetamol. See, again, as per the WHO triangle, whatever we are trying, you go ahead with paracetamol. But this is trauma is a different scenario where you should think of giving a higher analgesics initially itself. Trauma is one scenario because you are having an open fractures and all those things where your sensorium assessment, here this lady is completely conscious oriented, you are not suspecting any head injury. Maybe I prefer to give initially itself a smaller dose of an opioid. Maybe a fentanyl, a dose of 30 to 40 fentanyl, maybe associated with, you can still give paracetamol. I'm not denying the fact, but always remember, in trauma scenarios, you might need to go reversely what you have learned in your WHO triangle. So that is the WHO, that is the starting off with the paracetamol, then NSAIDs, then weaker opioids, then stronger opioids. That's how we routinely go ahead. So instead of that, there might be some changes that you need to keep in your mind. So the patient has come to your ED, you started with your primary survey, you went ahead with the airway, and with cervical spine, you found there is no, but as per Nexus criteria, she should having a C collar or not should have a C collar?
She should have been put a C collar because she had fell down from the scooter, but she came walking to the ER.
Okay.
So, and she on palpation there was no tenderness moving all four limbs.
Okay. She had any other distracting injuries?
No, she had primarily went to an outside hospital.
Somebody is coming off 8/10 pain. She's definitely having a distracting injury. She's having another injury. So here you can apply a Canadian C-spine rule. So as per the Canadian C-spine rule, it is definitely, doesn't need a collar. She's sitting up in the ER, she's able to move 45 degrees to both the sides without any pain, and mechanism of injury is not a high velocity injury. So what is the difference between Canadian C-spine rule and Nexus criteria? When you start looking to Nexus criteria, almost like many trauma patients requires a cervical collar. So that is a little bit safer. So when you are in doubt, better to use Nexus criteria. So like you have posterior cervical line tenderness, any focal neurological deficit, under the influence of alcohol, and the patient has any distracting injuries. So any other toxicity or altered mentation, you definitely go ahead and put a cervical collar. Here there is only one point that is suggesting is Nexus criteria is distracting injury. As per this, definitely you will put a cervical collar. But when you look into the Canadian, as you said, she has gone to another hospital where she has been evaluated and been walking to the ER without any, that doesn't rule out a cervical spine injury. You have to assess the patient. So what assessment is additionally in Canadian C-spine rule, you are asking her to move to either 45 degrees, both the sides. Then at that time, if you don't have any pain, then okay, you can think of not putting a cervical collar at that point of time. So here, because of that, you have not put a cervical collar, agreed to that. But the problem is that don't think of outside hospital. You should have your own assessment in all the trauma patient. It is irrespective, we can miss, because the pain or cervical spine injury is one thing we can all miss. It is not even at 10-15 years of doctors will miss this. So you should keep in your mind, airway with cervical. There is no harm in putting a cervical spine initially when you have doubt in your mind. Later on you can remove, well and good, okay. Then coming to the breathing part, you said air entry is bilaterally equal. So here what you will suspect, somebody is coming off abdominal pain. Where was the abdominal pain exactly she was complaining of?
Diffuse abdominal pain was there, but more towards the left side she was complaining.
Left apical. So left lower zone, I will be more concerned. I would like to know how is the air entry.
Air entry was bilaterally equal and there were adequate chest excursions.
Tenderness was not there.
Not there.
Okay, then coming to the circulation, here the BP is 140/90 with a heart rate of 108. And what was the treatment given in the outside hospital is what I wanted to know. Because there are two things that is very contradictory in your history. Not contradictory, the patient is not having hypotension but having a hemoglobin drop. HB drop of 8. That's what you said, no? Hemoglobin of 8. So, if the patient had a hemorrhage, what should happen to the blood pressure?
Hypotension.
There should be hypotension. So if she has gone to an outside hospital and if she has received a fluid bolus from there, that could be the reason why there is no hypotension. Whether she has received the treatment?
She had received analgesics and fluids from the outside hospital and then sent back home.
Okay. So again, two things that I am, again 140/90 BP. The reason for 140/90, excess fluid given also. what we wanted in this group of patient, we don't want an significant improvement in the blood pressure. We just wanted a map above 65. So the patient, what could, to my knowledge, I will say that this patient maybe had an initial trauma. Maybe her baseline hemoglobin would have been somewhere around 11, 12, we don't know. And she had a hemorrhage. Maybe there was a 1 to 2 gram of blood loss. She went to the hospital outside and they saw there was a hypotension. They pumped her with fluid, 1 to 1.5 liters they would have given, we don't know. And now the BP is on the higher side. Now the BP is on the higher side, what will happen? The clot will get dislodged now, and again the patient will start getting rebleed. So this patient is a potential risk for a rebleeding, and probably she will go for a significant hypotension. You don't want an aggressive blood pressure to be maintained in her. Okay. So then circulation was done. So there was no tachycardia. Maybe 108 tachycardia is there, still there. There is no acidosis and she was conscious oriented. So maybe she had come into a phase of a rapid responder. When you give fluids for the trauma patient, we will classify them as non-responder, transient responders and rapid responders. So we can put her as a maybe rapid responder. Okay, well and good. But 8 hemoglobin, you should definitely arrange for blood transfusion. So once you see 8 hemoglobin, definitely you should ask for it. So what is the usual response in hemorrhage? What will happen to the hemoglobin? What is the usual pattern?
Hemoglobin initially shows a higher value due to the hemo concentration, and then slowly it starts
coming down. So now it has come down. So that means she almost had lost. How much amount of blood she would have lost?
More than 1,500.
She was in class 3 or class 4 hemorrhagic shock, and after fluid transfusion, giving the fluid, she has come to it. But this patient definitely warrants an blood transfusion. So that is one more thing that I have given you. A patient with anemia, but there is no hypotension. If you are not finding any other cause for anemia, that patient needs blood transfusion. Like 8 hemoglobin, definitely that is not a normal hemoglobin for a patient. So she needs a blood transfusion. And most importantly, there is no adjunct here itself, you should give your tranexaminic acid. 1 gram of tranexaminic acid you have to give stat, then followed by infusion. So these are the 2 recommendations you need to keep in your mind. And most likely, if this patient hemoglobin is further dropping or further hypotension, that is the time this patient should be taken up for what? OT, and simultaneously you should keeping in your mind for a massive transfusion protocol, MTP, 1:1:1. And being a pregnant lady, being a lady on childbearing age, what is the second consideration that you need to keep in your mind? If you are giving blood transfusions,
O negative blood group.
If you don't get O negative, RH ISO, then you might require anti-D. So that is not for all group of patients. Just keep in your mind, trauma in ladies with childbearing age, 38-year-old. So still it's a childbearing age. So you need to keep that in your mind also. Okay, so that is one more thing. But pregnancy and trauma, definitely you need to think that. But here, you can just keep that in your mind, not for all the patients, but always think whether there is any other chance for hemorrhage also. A 38-year-old female may be pregnant, maybe after the trauma there can be an abruption or there can be something else. We are not sure, but here it is 100% due to trauma. So that is related to your circulation. So circulation, then you did your fast simultaneously and fast became positive. Why, you said left side of the side abdominal pain. Why right-sided fluid collection was there?
Fluid can get shifted to the most dependent part also.
So when you look into the embryology and anatomy, so when you look at the right hypochondrium, that is the most dependent part. So the first fluid, wherever gets accumulated in the abdomen, that is the initial phase, that recess area is what we will get the fluid in. So that doesn't mean that there is a liver injury. So that means there is some abdominal pathology, there is some free fluid in the abdomen, mostly a hemoperitoneum. So we don't know where exactly, but from the history what you said, it can be either a left lobe of the liver or it can be the spleen. So then that should be, our priority should be blood transfusion. Have we arranged blood transfusion?
Yes, we had arranged for the blood
transfusion, and it should be the most important one, and massive transfusion protocol should be taken care of. 1:1:1 or at least 2:1:1. And almost important thing is when you're transfusing calcium gluconate. So the patient will, when you are giving for multiple transfusion, what will happen? The blood, they are storing it with citrate. So when you are giving a lot of blood transfusion, there is a possibility of hypocalcemia. So that is a problem. So every after 1 or 2 pints of PRBC you are getting transfused, make it a mandatory to give 1 dose of calcium gluconate. So there can be hypocalcemia. So when you are doing this massive transfusion and all, that is a possibility. And here again, we are not 8 hemoglobin. When you ask me, technically you ask me during this time, 8 hemoglobin, at this moment I might be happy. I don't want to over treat by giving more blood to this patient. But if it dropping below 8, definitely yes. Why I am saying is this, because if this patient has come, how much fluid has she has received from outside, we don't know. Whether they have given 2 liters, 3 liters and all those things, we have no idea. So maybe she was over treated with fluid and she has gone in for an major hemorrhage after that also. The clot would have dislodged. Okay. So what are you said regarding disability and exposure. Why you want to prevent hypothermia?
Because if a patient comes in hypertension and initially till the blood products are arranged, if we go for a transfusion of the crystalloids, again the patient can develop hypothermia.
Okay.
If we are not covering the patient properly, also the patient can go into hypothermia.
So what is the problem with hypothermia? What will happen if there is hypothermia?
Acidosis.
It further worsens the acidosis and coagulopathy. So acidosis, coagulopathy and hypothermia. These are the 3 things that is going to kill the patient. It is not the hemorrhage that is going to kill the patient. In this group of patient, hemorrhage we can manage. But when you are over treating with all those things, when you are giving unwarmed saline, you have to give warm saline for this group of patient, then you are going to cause hypothermia. So you have to prevent hypothermia. So that's a very important thing. And again, if you're giving more and more fluid, what is happening? There is dilution. So your clotting factors are getting diluted. So you are going for dilution coagulopathy. So trauma-induced coagulopathy. Then the next thing is that you are giving lot of chloride containing fluids. So that is again increasing your acidosis. So again chance of coagulopathy. So that's a triad that you need to keep in your mind. So most importantly, what you need to keep in your mind, fluid resuscitation, yes, you need fluid resuscitation, but B, you should keep in your mind, it should be balanced. So that is what is all about balanced resuscitation, which we have discussed a lot of time for our cases. So this patient was not receiving fluid correctly. You want to give any antibiotics for this patient? Yes. What antibiotics you wanted to give?
We can give antibiotic metrogyl.
Okay, I wanted to give basically a gram-negative coverage. So that will be my first priority. If cefuroxime, ceftriaxone, a gram-negative coverage. But if there is an intestinal perforation also, then I will be thinking into of an anaerobic coverage. But just a liver laceration or a splenic laceration, you wanted to just go ahead with a basic antibiotic only. So the key things that in the emergency room will be our blood transfusion, balanced resuscitation, tranexaminic acid, very, very important. And this patient was hemodynamically stable. So that group of patient you could have taken up for this thing, CECT. So what after CECT? What are the treatment options after CECT?
After the CECT, we can classify the grade put into 5 grades of the splenic injury. And in that grade 1 comes with subhematoma collection, which is less than 10%. Or parenchymal laceration less than 1 centimeter in depth. Grade 2 comes with subcapsular hematoma from 10 to 50%, intraparenchymal hematoma less than 5 centimeter, and parenchymal laceration of 1 to 3 centimeter. Grade 3 comes with subcapsular hematoma more than 50%, or parenchymal laceration more than 3 centimeter, or intraparenchymal hematoma more than 5 centimeter. In grade 4, there is any injury in presence of splenic vascular injury, but the bleeding is within the capsule, and grade 5 is bleeding is outside the capsule.
It is shattered spleen.
Shattered spleen.
So only technically speaking right now only grade 5 spleen need a urgent splenectomy, or otherwise hemodynamically compromise is there. Grade 4 till now we can conservatively manage. So when you say grade 1, grade 2, grade 3, we can't remember this always, this dimensions and all these things. When somebody is saying it's a grade 5 splenic laceration, make sure that the surgeon is aware of this. You are going to get a patient with grade 5. Grade 5 means immediately to the OR, the patient should be going immediately splenectomy to be done. Whether there are any other options?
Embolization.
That is now very frequently being done, embolization, which all we can go ahead with. Embolization of
celiac artery can be done.
whichever there is a culprit vessel, you are able to identify that embolization is one important thing, like just like Ribova when we discussed regarding for aortic dissection and all. Similarly, embolization is an option. So mild like grade 3, grade 4, where you wanted to, there is some bleeding, but still you don't want to go for a splenectomy, definitely you can think of embolization. So embolization is one thing that in the last 5 years and all, we can think of doing it for these sort of cases. So these are the overview. What happened to this patient?
This patient was shifted to gastrosurgery department and serial monitoring of HB was done, and then patient had an HB fall, further HB fall from 8 to 6.6.
Okay.
So we had transfused the patient with 1 pint PRBC. Following, there was no HP drop, so serial monitoring was done for 4 days, and then patient was discharged hemodynamically stable.
Okay, okay. Suppose this patient have to underwent splenectomy. So post splenectomy, what are the concerns?
We have to give the proper vaccinations for the encapsulated organisms like pneumococci.
So that is the main issue. They can come with sepsis. So post splenectomy sepsis. Okay, fine. Thank you.
Thank you, sir.